Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by Carium, the telehealth platform enabling healthcare's digital transformation, helping you care for people within the fabric of their daily lives. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining us as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Jure Ivan, Chief Product and Strategy Officer at Lyniate. Drew, welcome to the show.
Thanks for inviting me.
So, Drew, what I always like to do before getting into the main part of the discussion is to give my guests a chance to give a little bit more of a background in terms of who they are and what they do. So the floor is yours.
Thanks. So Lyniate is a healthcare interoperability company. We focus on building tools for helping our customers integrate their systems to one another and integrate organizations to one another. My role at Lyniate is to be the Chief Strategy Officer, which is kind of a vague role, but it encompasses things like figuring out where we want to go next, tracking trends so that we're not surprised by them, and finding other counterparties within the ecosystem to work with in usually a partnership mode, as well as working with our customers to understand what they need and where they're going. So that's kind of where I fit in to the overall company strategy.
Yeah, you just kind of mentioned one of those hot button topics of interoperability. And before we start really pursuing that, I'm just out of curiosity, kind of what first got you into the healthcare industry?
Actually, I got into the healthcare industry not on purpose. I started my career as a software developer. And, I applied for a position for a software development role that happened to be in a healthcare IT company. And once I got there, I became fascinated by the domain and pivoted from software development to product management, and then started focusing on some of the less technical aspects of what was going on. So my focus as a product manager was not on the clinical aspects of the product. Because of my technical background, it was more on the interoperability aspects of the product. And that pulled me down the path of healthcare interoperability.
So kind of with that lead in, to you, what does interoperability mean? Because I feel like there's a lot of discussion around it, but maybe not getting into the actual technical definition of it or the technical aspects. So, having you give us a level set, I think would definitely be helpful.
Yeah, there is. I take kind of a very pragmatic approach to thinking about interoperability. The definition of interoperability usually includes the words "without any special effort on the part of the user." And I mean, I found that to almost never be true. There's always special effort on the part of the user to get healthcare software talking to one another. And I don't think that's bad or wrong. I think that there's oftentimes a lot of comparisons of healthcare interoperability to things like banking interoperability. You can use your ATM card at any bank's ATM, or cell phone network interoperability. You can use your cell phone even if you travel outside of the country and end up on a different carrier's network. And I think that healthcare transactions are much more complicated and nuanced and require a higher level of security and certainty than any of those other ones. And so it's never going to be as straightforward as that. Plus the fact that you have an ecosystem of vendors in healthcare that have different concerns, different motivations. And they're evolving at different speeds. And so you end up with all these different interoperability capabilities in the mix, as well as different levels of detail. And so you're always going to need some sort of a place to stand to do your work in order to tie together information from one system and another in healthcare. And I think that's perfectly fine. It's the reason we're in business. So of course I think that, but I think that trying to simplify interoperability in healthcare the way we have in other industries is probably never going to happen.
It kind of with that acknowledgement that there is a lot of difference between a healthcare transaction in terms of that interconnectedness as opposed to other industries. Kind of what challenges or what opportunities do you see to get people to actually understand that and move away from the kind of that recurring statement of, oh, well, it should just be like banking, or it should be like any of the other industries that you mentioned.
Yeah, I think the first thing is that it would be helpful for us as healthcare interoperability specialists to stop talking about it in those terms or comparing us to those other industries. And I think just acknowledging that interoperability isn't really a problem to be solved. It's not like we have this issue in the industry, and once we tackle it, we'll be done forever. Because it's not like that. It's a problem. It's not even really a problem. It's a capability that has to evolve alongside all these other capabilities. We think about when we rolled out EHRs as an industry, that was a problem to be solved. There were no EHRs, and we wanted everyone to have an EHR. So we went on a multi-year program to roll them out, and then we thought about optimizing EHR workflow and everything else that goes along with it. And now we're starting to think about, what other capabilities can we add into EHRs? And it's because, once you have that foundational capability in place, you want to continue evolving it over time. And, nobody's out there saying, why isn't EHR a solved problem? And similarly, we shouldn't be saying, why isn't interoperability a solved problem? Because it's the same thing. It's a capability that needs to evolve over time as everything else around it evolves. We're exchanging new types of information with new types of organizations. There's organizations now participating in interoperability that never have before in healthcare. And so, acknowledging that it's a continuously evolving landscape will help us get away from that idea that it's a problem that we just can't solve, and pivot our paradigm to be it's a capability that we're continuously working on.
Yeah, that's really well stated, because as you said, it's rarely are things just a one and done solution or one and done response to an issue. It's, I really like, as you said, it has to keep evolving. But from the evolutionary aspect, are the kind of new regulations that have been finalized and we're kind of in the process of kind of implementing and having to comply with, and by the regulations, really thinking about the interoperability and info blocking rules that came out as of 21st Century Cures Act. Mm-hmm. Do you see that as helping or hindering the recognition that this is an ongoing, evolving process?
Yeah, I see it almost as a lesson that the federal government is trying to teach. Because the way I think of it, the federal government paid a lot of money to incent adoption of EHRs in the 2008 to 2010 timeframe. And I think that there was a built-in assumption that once the data was stored electronically, it would be very easy to transfer it from one institution to another. And the rollout happened. The incentives were used to implement and adopt EHRs. But then that interoperability piece didn't come along for free, or included in the price as may have been assumed. And so I think the information blocking part of 21st Century Cures sort of circles back around and corrects that and says, not in so many words, but it's the federal government saying to the healthcare ecosystem, what we meant when we said start storing your data electronically was also make it easy to transfer from place to place. So in a way, I think it's a correction of something that wasn't explicitly stated in the HITECH Act. In another way, I think it's a little bit of a change to the status quo, which is, HIPAA says you have to share information when it's required. What the information blocking rules say are you have to share information always, unless it's one of these few exceptional cases. So it's really share by default rather than share by request, which is a shift that I don't think has been fully appreciated and will probably take years to fully make its impact felt in healthcare.
And kind of viewing the new set of regulations as the government trying to teach a lesson, as you said, even that doesn't necessarily seem to capture fully that concept you just described, because as you said, not only is it that the government's going back and saying, yes, we told you to now, store, create, and work with your healthcare information electronically, but it's also helping it go that step further, recognizing that it's not just enough to have the information going back and forth as it should have been among the call it the traditional players within healthcare, but also to individuals and everyone that the individual is identifying. And I think that, from my perspective, at least touches upon that last point you made around, the absent kind of those exceptions and info blocking. The aim does appear to be, let's open up the flow and have patients kind of give a little bit more of a direction and say over where their data is going to be going.
Yeah, that's exactly right. I mean, if you think about all the implications of this rule, it really does open up a lot of new capabilities for how that data can be used. And I think the change management of moving our thinking to that point of view is what has not been fully appreciated. It's going to take a long time. There's a lot of inertia, even among all parties, right? The hospitals that generate those medical records aren't prepared to do that. The payors aren't necessarily prepared to understand what that means for them. Even the patients are unclear on what these capabilities are. And I mean, we understand it because we're in the business, but imagine the average person. They have no idea that an anti-information blocking rule has been passed. So they're not going to realize the impact of it until vendors can start baking that capability into apps that they want to use, and they can start to see their clinical data flowing more freely in a way that is helpful to them, because it's really not the data that they care about; it's the features that data can drive that's going to change their healthcare experience.
Yeah, pointing out that most people probably are not fully aware of, if aware at all, of kind of that new kind of landscape that they can take advantage of, I think is very accurate. It's, I think it's very easy for all of us who work within the healthcare industry and start and kind of interact or have to understand with the impacts of these regulations. It's easy for us to see the potential for the sea change, but then the question becomes, how do you get that message out? And how do you get people to recognize kind of the full scope of rights that they can exercise?
Yeah, and it takes a long time. I mean, HIPAA is over 20 years old, and I think by now people sort of understand that there's special protections around their medical records. But how long will it take for people to understand similarly that there's information sharing requirements that are built into federal policy now? Probably not another 20 years, but it's not going to be overnight.
Yeah, and even if you get the message out, then the tag-along issue is the right message getting out, or is the message being understood correctly? Because your reference to HIPAA, it's, I think as the news cycles continually show, through the course of COVID, a lot of people think they understand what HIPAA is, but are throwing it out as a reason or reason not to do something for completely wrong reasons, which is always my concern about, regulations entering common parlance, because it's very easy to miss the mark of, what the actual impact is.
Yeah. And I mean, I expect you run into that more than I do, but for sure, I think there's well, first of all, it's not straightforward, right? There's a lot in HIPAA. It's extremely complex, and for the ordinary person, they probably boil it down to, my doctor can't share my medical record with just anybody, and that's not wrong, but it's also not complete, and it leads to a lot of problems and misunderstandings, I think.
Yeah, no, that's very true, and it's it's always helpful to start talking about it as well, because from the legal side, it's oftentimes we view it as one of the least complex healthcare regulations that are out there, because and that's probably just by comparison, because so many other ones become so convoluted and so opaque that when you have one that's relatively simple, you kind of get that feeling of, well, it should be a lot easier to understand this one. But as you said, there are a lot of kind of moving parts to it, and a lot of different interconnected pieces that need to be understood.
Yeah. I mean, not to go too far down this tangent, but I think the thing that most people know about HIPAA is when they go to a new doctor, they have to sign a paper that says that gives the doctor the right to send their data to an insurance company to get paid, and that's the most they know about it, and they don't realize that they have a right of access in there, as well as a right of privacy and all those things. So there's quite a lot of potential for education there, let alone the whole anti-information blocking regulations that came along so much later.
Yeah, no, definitely. And for those of you just joining, I'm talking with Jure from Lyniate. We've been talking about interoperability and the impact of new regulations. And Jure, I'd kind of like to take this chance to pivot a little bit in terms of that interoperability and start thinking not just about the interoperability of, and kind of that ease of access that we were talking about for individuals to get their own information or to have it going in different directions, but to think about, where opportunities lie for better interoperability and sharing of data between, the kind of traditional players within healthcare. So thinking probably about care delivery and insurance, because it's, I think that has been a pain point in the past, but it's also an area where, as we hopefully keep going down the value-based care road, you keep hearing discussions of, payers and providers need to be working better together. Mm-hmm. So would be interested to get your take on, what's happening in that realm.
Yeah, the way it was explained to me, which I really like because it made a lot of sense to me, is that payers are in the business of managing risk. Their whole business model is around understanding how much they're likely to have to pay for each member that's part of their plan, and then pulling that risk across the whole population of members that they serve, and then doing things using the data that they collect and the analytics they can apply to it to try and reduce that risk so that they can keep premiums down. And when you think about it, the payers are actually fairly poorly positioned to manage that risk because they don't have the same type of relationship with the members that the providers do. The providers are much better positioned to manage risk from the perspective of advising individual patients, on how to take care of themselves, how to stay well rather than getting sick. Just things like, staying, refilling their medications and getting the appropriate tests that are recommended and screenings at different points in their life or based on their condition. So the providers are actually better positioned to do the job that the payers are doing. And as a result of that, the whole, value-based care movement is about transferring risk from the payers to the providers where it can better be managed. Unfortunately, the providers are poorly equipped to do some of the population level stuff. They don't have the right tools for identifying patients that have gaps in care, for example. They're perfectly positioned to close the gaps in care, but they're not well positioned to do the analytics required to identify those gaps in care. So what we're seeing is that the providers have the necessary data to help manage risk. The payers have the right tools, and what we're starting to see is better sharing of the data and the tools so that everyone can improve healthcare. So what we're seeing is the payers starting to transfer some of the risk to the providers. And along with that goes the tools that, the analytics and the other types of tools that can help the providers manage the risk better. But in exchange for that, the providers need to share the data back to the payers so that they can put that data into their tools and drive the right outcomes. So, that's historically been, we've been on a very slow path toward that, but that's where we're getting to right now. And in the coming years, I think it's what we're going to see.
Based off that description, it really sounds, like there's a bleeding of the roles of the payers and providers. And maybe instead of having each view the other as on different levels or different, kind of different interactions or impacts with everybody, it's trying to create more of a collaborative environment where there's more of a we're all in this together style relationship. So do you see that type of mentality arising, or is that still yet to come?
We're on the way, and I think you're right. I think the goal here is to put everybody on the same side: the payers, the providers, and the patients, so that they're all thinking in the same way. Historically, under the fee-for-service model, there's been animosity between the providers and the payers because, providers want to bill for as much as they can, and payers want to pay for as little as possible. if you just follow the money, that's what their motivations are. And I think what value-based care lets us realize is that everybody wins if we can do better at prevention. The payers will end up paying less overall to keep patients well versus make them healthy after they're sick. That's better for the patients, and that savings can be shared with the providers, so that everyone's pulling in the same direction. We're starting to see some evidence of that, I think, but it's like turning a battleship. It's not going to happen quickly.
And considering that change and that kind of fundamental shift, what types of data should be focused on first, or are really kind of critical for helping to drive that change of direction? Because I suspect it's probably not just one side dumping all of its data on the other. I suspect that there's probably some type of selection process that should occur.
Right. And when I first started hearing these conversations, it was the payers saying we could do a lot better on prior authorization and gaps in care and risk adjustment, all these things, if we had the clinical data. And then the question was, well, what clinical data? And they hadn't thought of that. They hadn't thought that there was quite a lot of richness within the clinical data. The answer that they need is within the clinical data, but they don't need all the clinical data. So you're exactly right that there needs to be some filtration, and I think that that's kind of the point where we are right now. Is we're starting to do enough pilot projects and proofs of concept to start to understand what are the high value pieces of data that can be transferred from the provider to the payer, so that when you have a specific individual's record, you can take all the claims data and add these strategic pieces of clinical data to get a much better picture of what's going on with that person, and then be able to advise, on risk scores, gaps in care, all the things that the provider needs to be able to keep that patient healthier.
And kind of thinking through that selection and that refinement, is that helping also to identify gaps in the data on either side, and then potentially trying to drive solutions to collect that missing data?
Yeah, I mean, what we're finding is that because the two worlds have evolved so separately and with such different motivators, some of the basic conversations are even hard to have. You have problems like payers talk about members and providers talk about patients. And at the end of the day, they're the same human being, but from a data modeling perspective, they're very different because the provider may be tracking a medical record number, which technically refers to a medical record, not to a patient. The membership is, tied to a specific time period. It's tied to a specific plan within the payer's set of plans, and it's not trivial to tie a patient to a member, because you need to know, what was the date of service? Was it before they changed plans or after? There's actually not even always a good correspondence between the patients and the members, because payers can only see the data for members that they cover, and if the membership changes to a different company on a certain date, then the payer loses their right to see that data. So just knowing like what date something happened on determines whether the payer can see that clinical data or not. And as a result, it makes it very difficult for each side to really negotiate. So I think it's less about identifying gaps in the data and more about colliding head on with these differences in data models that both sides have curated over the years.
And that definitely seems like it then keeps circling back to the point you were making earlier of trying to find better alignment and getting a common language established, as opposed to essentially creating two ships passing in the night, where they might be talking about the exact same thing, but because the terminology is completely different, it's either hard to reconcile it, or they just keep trying. One side might just keep trying to impose its view on the other.
Yeah, and a potential place to reconcile it is with the patient. If the patient could download their clinical data and their claims data, it starts to make a bit of sense, because now it's in the hands of the one party that is common to both relationships. It's in the center of that Venn diagram. But to put that burden on a patient to first of all, just access the data and then try to reconcile it across two different sources. That's a bit unfair to put into the hands of an average consumer. But it happens to be kind of the best place to do it. That's the one person that has complete rights to both sets of data and the best perspective of which parts of the data are related to which other parts. It's just an unsolved problem because you don't want the patient to have to be the expert in these different data models.
No, I think that's definitely right, because it's, while I suspect there are definitely some patients or individuals out there who would be more than happy to play that role, while they might be the most vocal kind of subgroup, it's also most likely going to be a minority as opposed to the majority of individuals. So it's, kind of almost like everything, you need to enable a continuum or a sliding scale of where you want to fall and, help ensure that the right tools exist to empower individuals wherever they might fall on that scale.
Yeah, and some technology vendor will build a tool that makes it easier, I'm sure, because if you think about the way data is used to drive advertisements and retail and transportation, they do incredible things with minimal views into the data. So, imagine what they could do with the same techniques if they applied it to healthcare data, and it just hasn't happened yet. So that's something that I think will happen, maybe in the next 5 years, but it hasn't in the past 5 years.
And that would seem to maybe tap into, what maybe a potential shift that might be needed with regard to how the healthcare data are treated, since kind of going back to some of our discussion earlier around, the expectation of privacy and the limited use around it, I think most people might not want to see that same broad, expansive application applied to it. But Drew, believe it or not, we're already almost out of time. So I want to kind of pose one final question to you to see, what has you most excited for the next, say, 12 months when it comes to the interchange of data and how the different players are working together?
Yeah, for us, it's really about what are the new use cases we can drive by connecting these systems together, and I think that we have good solutions for tying together systems within an organization. We're starting to get good at tying together sources across separate organizations. But then what's next? How do we embed data from a multitude of organizations into a specific provider's workflow? How do we get the patient involved? Pulling in some of these other parties that have not traditionally participated in interoperability or have only done so through very limited ways, I think is going to enable a lot of new patterns in healthcare and treatment that should be exciting.
Yeah, no, I think a lot to watch for. But as I said, believe it or not, we are out of time. I want to thank my guest, Drew Ivan, for a great conversation today. Thank you. And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.